Assalamu alaikum. This lecture about clinical trying and adjustment. After the lab procedure has been complete, the casting restoration is now ready to be tried in or checked on the prepared tooth inside the patient mouth. In most cases, this procedure can be accomplished without anesthesia. It gives us the benefit of unimpaired tactile sensation that is of great value during occlusal adjustment, but sometimes we use anesthesia, especially with uncomfortable patients. The first step in the clinical trying and adjustment is the removal of the temporary crown. We should be careful in the removal of the temporary crown. We should remove the temporary crown along its path of insertion, not rock the temporary crown back and forth, because this will destroy the preparation. We should use a special instrument like backhouse towel clamp or GC plier. This picture shows us the backhouse towel clamp and GC plier. As you see that the GC plier has a rubber ended and there is a carborundum powder beside it. We dip the GC plier in the carborundum powder before we grasp the temporary crown. The next step is to remove all the cement and debris and clean the tooth carefully, because any remnant of cement will interfere with the setting of the final restoration. The inside of the casting should be inspected prior to setting, because no contact should exist between the prepared tooth and the internal surface of the casting. We need a space of 25 to 35 micrometer for the luting agent or cement, so any contact should be identified and relieved by grinding the internal surface with a small round carbide bit. This procedure can be repeated for several times with the aid of pressure indicating paste. Now set the restoration on the prepared teeth with a slight pressure. Then check the interproximal contact area. Any tight contact area can be adjusted using rubber wheel in a slow speed handpiece. The interproximal contact area should be tight as the others in the mouth. Dental floss is used to check the interproximal contact by passing it between the restoration and the adjacent natural teeth. It should be passed with a slight pressure. When the dental floss can't pass through the contact, this indicates that the contact is heavy. It must be reduced. But when the dental floss passes easily, it indicates that the contact area is under control. There is a deficiency in the contact area. In this case, the restoration should be repeated or corrected by adding a solder to that area. If the contact area is perfect and the crown is not seated completely, this might mean that there is an interference from the inside, maybe metal bubbles or undercuts. We use a pressure indicating paste or a silicone wash to identify this interference. We mix an equal amount of a silicone base and catalyst and put it inside the cast restoration. Paint the inside of the crown with the silicone wash, then place the crown on the prepared teeth and wait until for the complete setting. After that, we remove the crown and see if there is any interference points. After the material sets, remove and check for areas of interference. We mark the interference with pencil, then remove the wash After that, we remove the interference area with a carbide bit. We can repeat this adjustment for several times until the crown is seated. Otherwise, you should repeat your restoration. The margin of the restoration is the most critical area of the restoration. We should have complete fitness between the restoration margin and the finishing line of the preparation. We can evaluate complete setting visually, radiographically, and by the use of Explorer. To check the marginal integrity of the crown restoration, we should use sharp periodontal probe. The probe should be moved in a two direction. We should have complete fitness between the restoration margin and the finishing line of the restoration. How to evaluate the marginal integrity? We move the probe from the restoration toward tooth surface. If it passes smoothly without any interruption, the margin is okay. However, if there is any interruption during this movement, this indicated underextended margin. And then we move the probe from tooth surface toward restoration margin. If the probe catch by the margin, this indicated overextended margin. But if the probe passes smoothly in the two directions, this means the margin extension is correct. When there is a space between the restoration and tooth surface at area of the finishing line and the probe, this means open margin. According to this evaluation, the marginal defect may be first, short margin or underextended margin when the margin of the crown restoration lies short of finishing line of the prepared tooth. Second, long margin or overextended or overhanged margin when the margin of the crown restoration lies beyond finishing line of the prepared tooth. Third, open margin when the margin of the cast restoration is within finishing line, but there is a space between the restoration margin and the prepared tooth. Fourth, over contoured margin, the margin within the finishing line, but they are bulky. In the figure A, we see an ideal margin, but in the figure B, we see a closed margin, but it is underextended. In the figure C, the margin is opened and underextended, while in D, the margin is closed and overextended. In the figure E, the margin is overextended and open. These defects, some of them can be corrected, but other defects cannot be corrected, and we should remake the crown again. The restoration should then be examined for stability. It should not rock or rotate on the prepared tooth when the force is applied on. After complete setting, the occlusal relationship is adjusted in centric and eccentric movements using articulator paper, and any occlusal prematurities can be relieved by greenstone bar. As we said that the margin of the restoration is the most critical area of the restoration, and we should have complete fitness and adaptation between the restoration margin and the finishing line of the preparation. And some defects of the margin are over contoured or open margin, and these defects can be corrected to obtain at least 1 mm width margin and closely adapt to the tooth surface at the area of finishing line to prevent the micro leak. Marginal discrepancy such as overextended or over-contoured margin can be corrected easily. We can reduce this overextended or over-contoured margin from the axial surface only, not from underneath. And we should be careful because incorrect adjustment sometimes may result in a deficient margin. In the case of open margin, we can closely adapt the cast restoration margin to the tooth surface at the end of the finishing line by the use of burnisher or dull bit. We use the burnisher to press the margin against the tooth surface. After that, we should polish the margin by polishing a stone if the margin is supragingival, but if the margin is subgingival, no intraoral finishing is desirable because of the risk of damaging for the tooth and periodontal tissue. Is ready now for polishing to provide smooth, shiny restoration. And the purpose of polishing are to obtain glossy surface that is less susceptible to plaque deposition and to increase the tarnish and corrosion resistance beside the good appearance. All the axial surface should be polished. We have different polishing pairs and each pair has its specific function. In this picture we see different polishing pairs.